The connection between testosterone and prostate cancer. Following lung cancer, prostate cancer is the second most common form of cancer in men and is the most common malignant tumor of the urinary system. Tackling the battle of cancer is far from easy, though it is possible. Learning more information about the disease, including the causes of it and the methods that it spreads, can help to determine the best treatments, as well as methods of prevention. Unfortunately, prostate cancer is known to be common among older males. As the prostate is a male sex gland, it is heavily influenced by the primary male sex hormone, testosterone, which is produced by the testicles. The common question is whether this hormone plays a role in prostate cancer as well as prostatitis. There are over 23 types of prostate cancer, 95% of which are adenocarcinomas. Factors that may contribute to the risk of one developing prostate cancer can include age, weight, genetic susceptibility, environmental factors, smoking, and medication. It is noted that the risk of development of prostate cancer usually increases with age. It has been shown that most of the time, low testosterone levels slow the advance of prostate cancer, with some exceptions. Certain drugs have been known to slow down prostate cancer. These drugs commonly work by inhibiting androgens, which includes lowering testosterone levels. A part of the significance of testosterone replacement therapy, TRT, is that some men can experience symptoms from the low levels of testosterone and in some cases may consider using testosterone replacement drugs later following the removal of the cancer. Drug-resistant forms of prostate cancer exist as well, which show that not all cases of prostate cancer should be treated the same. It is generally known within the medical field that increased levels of testosterone lead to an increase in malignant cells of prostate cancer. Other studies have also shown that it is possible that there may not be a link between testosterone levels and the risk of developing prostate cancer. Additionally, some studies show that even though it is known that higher levels of testosterone can lead to increased proliferation of prostate cancer cells when the cancer is already present, the high levels of the hormone may not necessarily lead to an increased risk of developing prostate cancer. In an article, Stephanie Watson, a writer who specializes in consumer health, writes, "The median age of diagnosis is 66, with the majority of diagnosis occurring in men between the ages of 65 and 75. Watson also says, "Eat a mostly plant-based diet. Increase the number of fruits and vegetables in your diet, especially cooked tomatoes and cruciferous vegetables like broccoli and cauliflower, which may be protective. Cut back on red meat and full-fat dairy products like cheese and whole milk. Men who eat a lot of saturated fat have an increased risk of prostate cancer." Experts have said for many years that having a healthy diet can help lower the risk of developing cancer and other diseases. In addition to this, it is also noted that the omega-3 fats found in fish, such as salmon and tuna, can help lower the risk. Stephanie Watson also mentions that having a body mass index, BMI, of 30 or higher can lead to having an increased risk. It is commonly mentioned that smoking tobacco leads to an increased risk of cancer. In most cases, living a healthier lifestyle and having a healthy diet can help significantly to prevent the development of various forms of cancer. According to Stephanie Watson as well, some common symptoms can include an urgent need to urinate, trouble starting or stopping the urine flow, a weak or dribbling urine flow, pain or burning when you urinate, trouble getting an erection, painful ejaculation, blood in your urine or semen, pressure or pain in your rectum, pain in your lower back, hips, pelvis, or thighs. In addition to this, Jeffrey Turner, MD, says that some symptoms can include increased body fat, weight gain, low sex drive, fatigue, anemia, depression, poor memory, osteoporosis, and a higher risk of diabetes. In some cases, prostate cancer is detected before the patients begin experiencing symptoms. Most commonly, prostate cancer is measured by a prostate-specific antigen, or PSA test. A commonly used test for prostate cancer is a digital rectal examination, DRE, which is recommended for men aged 50 and older. This test involves the doctor's fingers probing the surface of the prostate to detect any areas of suspicion. Prostate-specific antigen is a protein produced by the prostate that may be found in high levels in the blood when a person develops prostate cancer or other diseases of the gland, such as prostatitis. A reason that both tests may be used for the identification of prostate cancer is that not all forms of prostate cancer will be detected by the PSA test. For example, according to Joel T. Nowak, MA and MSW, neuroendocrine prostate cancer, unlike adenocarcinoma types of prostate cancer, does not make PSA. They are also not responsive to hormone treatments as they lack the androgen receptors found in other types of prostate cells. They appear to produce their own hormones that can then fuel other forms of prostate cancer cells, rendering the hormone manipulations, ADT, we use ineffective. According to David A. Kramer, MD, many physicians today routinely do both a DRE and PSA test each year on their older male patients, so that if cancer does develop, it will be found at an early age, making it easier to treat. These tests may be ordered in men younger than age 50 if they are at high risk for the development of prostate cancer. The combination of a DRE and PSA test can detect approximately 80% of all prostate cancers. The DRE is done more commonly in older patients because as the risk increases with age, it would be more beneficial to detect the possible prostate cancer early. To add to this, David A. Kramer also says, a new variation of the PSA test shows how much of the material is bound to other protein in the blood and how much is free. This procedure may be more accurate and could well indicate whether either prostate cancer or BPH is present. The information that can be provided from this new variation of the PSA test can be used to provide a better diagnosis and prognosis for the patient. If a patient is suspected of having prostate cancer, further testing may be ordered, such as a prostate biopsy. After a patient's PSA test shows a certain level of PSA or a DRE exam result shows an abnormality, this procedure may be done for further examination to confirm the diagnosis of prostate cancer. According to Latacharov, PhD, prostate biopsies can be performed in 3 different ways: by inserting a needle through the perineum, the area between the base of the penis and the rectum, by inserting a needle through the wall of the rectum, or by cystoscopy. Based on the information giving this following type of testing, a prognosis can be made along with input from the patient. They may begin using medications for chemotherapy, choose radiation therapy, or they may choose to undergo a prostatectomy. Many of the medications that are commonly prescribed to patients with prostate cancer work by blocking the production of testosterone. It is known that common therapies, known as hormone therapies for prostate cancer, involve the blocking of androgens, which are a group of hormones that are present in both males and females, and most commonly are testosterone and androstenedione. Androstenedione is another steroid hormone and an intermediate in the synthesis of testosterone. In most therapies for prostate cancer, androgens are blocked. According to the American Cancer Society, some of the chemo drugs used to treat prostate cancer include docetaxel, Taxotere, cabazitaxel, Givantana, mitoxantrone, navantrone, estromustine, MSIT. Though these are commonly used drugs for the treatment of prostate cancer, the American Cancer Society also says that there are currently 50 drugs that are mainly used for the treatment of prostate cancer, and more are being developed. According to an article from the University of Leuven by Wout de Villiers, Florian Handel, Gaetan Devos, Stephen Jonu, and Frank Claessens, different prostate cancer therapies consequently focus on blocking the androgen receptor pathway. Clinical studies reported tumor resistance mechanisms by reactivating and bypassing the androgen pathway. Preclinical models allowed the identification, confirmation, and thorough study of these pathways. This review looks into the current and future role of preclinical models to understand resistance to androgen receptor targeted therapies. These have been proven many times to be successful. To do this, medications are used to slow down the production of testosterone and androstenedione. In many cases, high androgen levels promote the growth of the cancer cells. Dana-Farber Cancer Institute references a paper by Dana-Farber investigators that discovered that there has been found to be surplus production of a protein known as CREB5 in prostate, brain, and kidney cancers. An article by Dana-Farber Cancer Institute writes, "The discovery published in Cell Reports suggests that drugs targeting CREB5 could be effective in prostate cancers resistant to AR blocking drugs. Although such drugs do not yet exist, they are under development. This information can provide better direction for the development of drugs in the future. This also could be useful in other tests for prostate cancer. Though these treatments are not effective in every case, they usually are in the process of treatment. This shows that in some cases of prostate cancer that have already been diagnosed and are present, that there is a link between the growth of prostate cancer and androgen levels. As shown by a study in the 1940s, Stephanie Watson writes, researchers Charles Brenton Huggins and Clarence Hodges discovered that when men's testosterone production dropped, their prostate cancer stopped growing. The researchers also found that giving testosterone promotes prostate cancer growth. As further evidence, one of the main treatments for prostate cancer, hormone therapy, slows cancer by lowering testosterone levels in the body. The belief that testosterone fuels prostate cancer growth has led many doctors to avoid prescribing testosterone therapy for men who have a history of prostate cancer. On the other hand, not all forms of prostate cancer are affected by the drugs that are used. Whether or not testosterone is the culprit may depend on the form of the prostate cancer. As much of this research shows the link between the levels of testosterone and the growth of prostate cancer in patients that already have been diagnosed, there is not enough evidence to prove that this will always be the case. It does not lead to the conclusion that having high levels of testosterone leads to a higher risk of developing prostate cancer. It has been mentioned that the peak of testosterone production is usually seen in the ages of the 20s and then begins to slowly decrease, and that most men who are diagnosed with prostate cancer are at or over the age of 60. According to an article by Gio Espinosa, the likelihood of developing prostate cancer increases with age, with the average age at diagnosis being 66 years. Not all cases respond to the drug therapies that are most used in the treatment for prostate cancer, which work by blocking the androgens and then lowering the testosterone levels. According to a study done by Jason E. McCod, Kevin L. Billups, and Ellen W. Parton, there is no clear evidence that elevations in endogenous testosterone levels promote the development of prostate cancer in humans. As a result of experimental and historical data on the progression of prostate cancer following TRT, there has been widespread belief that TRT will promote disease progression in prostate cancer patients. Despite these fears, there are a growing number of studies demonstrating no increase in prostate cancer incidence among men on TRT. Though it may be a theory, it is at least known that testosterone can fuel existing prostate cancer. Other factors must also be considered for each patient. A study performed by Joel T. Nowak concludes the relationship between total testosterone and prostate cancer has been an area of interest among physicians for decades. Conflicting results have been reported on the relationship between total testosterone and subsequent prostate cancer. Much of this controversy appears to be based on conflicting study designs, definitions, and methodologies. To date, no prospective study with sufficient power has been published to unequivocally resolve the issue. The preponderance of studies of the safety of exogenous testosterone in men with a prostate cancer history suggests that there is little, if any, risk. However, because the risk has not been proved to zero, the most prudent course is to follow such men with regular prostate-specific antigen measurements and digital rectal examinations. This article claims that in some forms of prostate cancer, particularly neuroendocrine prostate cancer, the cancer cells may neither make PSA nor respond to hormonal treatment. This is unlike the adenocarcinoma forms. TRT is commonly used for the treatment of hypogonadism, which is a condition where the body's hormone levels leading to the development of secondary characteristics are too low, usually starting from puberty. This condition is caused by the sex glands producing little to no sex hormones. As for the cases that are drug resistant, Dana-Farber Cancer Institute writes, Drugs that block or inhibit the receptor can halt the cancer, but not all patients benefit from them, and nearly all those who do not respond eventually become resistant. Scientists have found that resistance often occurs because the androgen receptor regains the ability to switch on the cell's growth machinery even when the receptor is plugged with the drug molecule. But researchers also know that cancer cells usually harbor more than one backup plan. They have a variety of ways circumventing a drug that initially works well. In a recent paper, Dana-Farber investigators uncovered one such mechanism: surplus production of a protein called CREB5. They found that advanced prostate cancers with an overactive CREB5 gene, or with too many copies of it, were able to proliferate after treatment with one of the newest androgen receptor inhibitors. This helps to provide the counter-argument that higher testosterone levels may not necessarily be linked with prostate cancer at all. An article by Alvaro Morales and D. Robert Siemens mentions as well, in the prostate, testosterone acts mostly as a prohormone. The effective androgen is the more potent dihydrotestosterone, or DHT, which is converted from T through the action of 5-A reductase. Different organs have variable amounts of 5-alpha reductase enzymes 1 and 2. 5-alpha reductase 2 is more prominent in prostate, external genitalia, and skin, and its deficiency translates into minimal prostate growth in the presence of ambiguous external genitalia in boys, while puberty exhibit the anticipated increase in muscle mass in male habitus. The glandular epithelium and a subset of endothelial cells are the primary androgen target structures within the prostate. DHT acts on the androgen receptors of these tissues to generate a variety of androgen-induced stromal peptide growth factors of andromedins, leading to androgen-mediated mitogenic effects and survival signaling. Androgen deprivation, on the other hand, results in insufficient production of andromedins, which in turn upregulates the production of transforming growth factor beta sub 1, CCF beta sub 1, that signals the apoptotic cascade in the secretory compartment of the prostatic epithelium. Understanding the mechanisms of androgen-dependent prostate cancer cells growth, differentiation, and death is important because the manipulation has major consequences in the treatment of prostate neoplasms, which discuss the androgen receptor signaling in the cancer cells. In most cases that are treated successfully with drugs, the hormone dihydrotestosterone acts on these androgen receptors to increase the survival of the cancer cells. This is where the role of the drugs come in to cause androgen deprivation. On another hand, an article by Serina, Cheung, Pallavi, Jain, Jonathan, Saeid, Shahidi, Chung, andMarianne, Koritzinsky says, aberrant androgen receptor signaling is the major driver of castration-resistant prostate cancer. Tumor hypoxia increases androgen receptor signaling and is associated with treatment resistance in prostate cancer. Following this, it says, HCHOC protein 27, or HSP27, is a molecular chaperone that is activated in response to heat shock and hypoxia. HSP27 has previously been reported to facilitate androgen receptor nuclear translocation in a p38 mitogen-activated protein kinase, or MAPK, dependent manner in castration-sensitive prostate cancer cell lines. Here we evaluated the potential for inhibiting p38 MAPK/HSP27 experimental models of CRPC. We inhibited p38 MAPK with SB203580 in prostate cancer cell lines and measured HSP27 phosphorylation, androgen receptor activity, cell proliferation, and chronogenicity under normoxia and hypoxia. Androgen receptor activity was measured using an androgen response element-driven reporter assay and qPCR to measure expression of the androgen receptor target genes. The article later says, our results indicate that p38, MAPK, and HSP27 are activated under normoxia and hypoxia in response to androgens in CRPC cells. p38, MAPK, and HSP27 are activated under normoxia and hypoxia in response to androgens in CRPC cells. p38, MAPK inhibition diminished HSP27 activation and the hypoxia-mediated increase in androgen receptor activity. Additionally, inhibition of p38 MAPK activity decreased proliferation and survival of QRPC cells in vitro and prolonged the survival of tumor-bearing mice. These results suggest that p38 MAPK inhibition may represent a therapeutic strategy to disrupt androgen receptor signaling in the heterogeneous CRPC tumor microenvironment. This describes more in detail how some drug-resistant forms of cancer may gain independence from testosterone to continue to proliferate. Another commonly raised question is whether testosterone would be linked to the risk of developing prostate cancer or if it plays a role in prostate cancer that already exists. As shown by a research study, an article by Gio Espinosa says, in test tubes, testosterone demonstrates an increase in prostate cancer in numerous cancer cell lines, but apoptosis, which is programmed cancer cell death, once androgens are removed. A similar response is found in rat studies. Androgens promote tumor progression under androgens are withdrawn, then causing regression of prostate tumor cells. From test tubes and rat studies, one can easily think, that's it, case closed, testosterone fuels prostate cancer, thus low testosterone in men is best for prostate cancer prevention. But in analyzed human studies lies the paradox. Later in the same article, Espinosa says, here's the kicker, not only is there no causal relationship with high endogenous testosterone and prostate cancer, but low testosterone may cause the disease. One such clinical trial demonstrated a high incidence rate of aggressive, more deadly type of prostate cancer among men with low testosterone defined as greater than 7.6 nmol. Similarly, a group of Chinese men, 110 total, showed greater high-grade prostate cancer, higher Gleason score, in men with low testosterone. Beyond analyzing staging with Gleason grade on biopsy, a high-risk disease has been associated with low testosterone after prostatectomy. For example, almost 700 men undergoing prostatectomy had their morning testosterone levels taken with surgical pathology outcomes and observed a significant risk of advanced disease that included seminal vesicle invasion in severely hypogonadal men. To add to this point, Espinosa writes, lastly, some patients can benefit from testosterone therapy after prostate cancer diagnosis. One meta-analysis looked at about 2,300 men with low prostate cancer with less than or equal to of a Gleason score of 6 who underwent testosterone treatment and showed short-term safety with no prostate cancer progression regardless of route of administration. Testosterone replacement therapy after prostate cancer diagnosis is a viable option in hypogonadal men, but such patients need close monitoring by a knowledgeable physician to assure against cancer progression. As always, natural and lifestyle options to increase testosterone and overall health, particularly in men with prostate cancer history, should be exhausted before considering exogenous testosterone use. Also adding to this point that having a healthy level of testosterone can help to lower the risk of prostate cancer, Jeffrey Turner writes, despite historical evidence indicating that testosterone is usually bad for men with active cancers, some avant-garde researchers have been hypothesizing that testosterone administration to castrate-resistant patients may help in restoring hormone sensitivity and thus aid in transforming bad cancers into a less aggressive phenotype. The emergence of something termed bipolar androgen therapy has now surfaced. Bipolar therapy is the concept of rapid cycling between high blood levels of testosterone and low blood levels of testosterone using hormone blockade and testosterone supplementation in a cyclical fashion. Many sources claim that there is not a concrete link between the hormone testosterone and the risk of development of prostate cancer. An article written by Obesity, Fitness, and Wellness Week writes, according to the news editors, the research concluded, while higher PSA levels are associated with higher testosterone levels, the interaction between Gleason score and testosterone is unclear and merits further study. Some studies that have been done have shown that there is, in so many cases, a link between higher levels of the hormone and PSA levels. As there are different forms of prostate cancer, some may be more responsible to the hormone testosterone than others. To add to this, Morales and Seaman say, more recently, additional systematic reviews and meta-analyses have addressed the same topic, and a consensus 1718 now exists that PCA risk is unrelated to endogenous serum androgen concentrations, and specifically, men with higher endogenous T are at no greater risk than men with low serum T. It is also pertinent to keep in mind that strong epidemiological evidence exists for a variety of causes influencing the development of PCA independently of sex hormones. They include non-steroid hormones, genetic susceptibility, sexual transmitted agents, diet, and environmental factors. Whether any of these, alone or in combination, work synergistically with sex steroids has not been conclusively established. In addition to this, Stephanie Watson writes, a 2016 meta-analysis of research found no relationship between a man's testosterone level and his risk of developing prostate cancer. Another review of studies showed that testosterone therapy doesn't increase the risk of prostate cancer or make it more severe in men who have already been diagnosed. This can be brought back to the mention of that most patients who are diagnosed with prostate cancer are over the age of 60, meaning the production of testosterone has decreased. According to a study by Jason E. McCaud, Kevin L. Billups, and Alan W. Parton, however, there is no clear evidence that elevations in endogenous testosterone levels promote the development of prostate cancer in humans. As a result of experimental and historical data on the progression of prostate cancer following TRT, there has been widespread belief that TRT will promote disease progression in prostate cancer patients. Despite these fears, there are a growing number of studies demonstrating no increase in prostate cancer incidence among men on TRT. Furthermore, in studies involving a small number of patients, there has been no discernible increase in disease progression in prostate cancer patients on TRT. While data from large, prospective, randomized controlled trials are absent, TRT in select prostate cancer patients is likely safe. In the end, the use of TRT in prostate cancer patients is still considered experimental and should only be offered after well-informed shared decision-making and with close monitoring. These sources may provide further evidence in showing that testosterone may have a link with prostate cancer, even though it may not necessarily lead to an increase of development of the disease. These sources make it clear that the responses to testosterone may be subjective to the patient and the form of prostate cancer they may have. Given the research studies that have been performed, it can be gathered that even though testosterone does play a role in prostate cancer, having high levels of the hormone does not necessarily lead to an increased risk in the development of the disease. Studies have shown reliably that in most of the cases of prostate cancer, hormone therapy has proved to slow down the growth of the disease. New drugs currently are being developed that may make a better prognosis for prostate cancer patients. An article by the Medical Letter says, the FDA has approved darolutamide, an androgen receptor inhibitor for oral treatment of non-metastatic castration-resistant prostate cancer. Darolutamide is the third androgen receptor inhibitor to be approved for this indication. To go along with this, the article also says, apalutamide has just received accelerated approval from the FDA for treatment of non-metastatic indication. Apalutamide is an oral anti-androgen that binds to the ligand-binding domain of the androgen receptor. This can provide hope to many people globally who are at risk of or suffer from prostate cancer. Also in the United Kingdom, a new drug for patients with advanced prostate cancer has been recommended. An article by Miranda Bryant reports, thousands of men in the UK with advanced prostate cancer are to benefit from a new drug after it was approved for NHS use. The National Institute for Health and Care Excellence has recommended enzalutamide as an option for treating some types of prostate cancer. These are advancements in medicine that can help save many lives. It is also clear by these reports that having high levels of the hormone does not necessarily increase the risk of developing prostate cancer. However, it also must be taken into consideration that a study has shown that men with lower levels of testosterone have had a higher incidence rate of developing prostate cancer, showing that it may be beneficial to have a well-balanced level of the androgen.